What are the odds of Merkel reoccurrence and survival?
We know that among all people who are newly diagnosed with Merkel, 40% will have it come back. That's a much higher number than the other skin cancers, the more common skin cancers. And that number varies a lot. I believe the single lowest number is around 10 to 14%. And that would be a woman with a very small tumor on, certain parts of the body that definitely has no involvement in the lymph nodes. In contrast, men do a little bit worse in general. A man on the head and neck who's immune suppressed, who has it in several lymph nodes, the chance of that coming back is like over 80%. So it varies a lot, somewhere between 10% and 80%, given various risk factors, of the chance it will come back anywhere. Then we have the issue of, does it come back near the primary site on the scalp? Or does it come back in the lymph nodes? Or does it come back in the liver or somewhere else? Each of those things has an associated risk. We have simplified things by just saying the chance that it's going to come back anywhere. Because frankly, a lot of times it comes back in two places at once. And you might as well just say the chance it's ever going to come back at all. And once that chance goes to really low, we just celebrate and we're done. Then we have the risk, the chance that we can beat it. So that has, if it comes back in a place where we can't just cut it out with a little more surgery or just radiate, that has improved by tenfold. Prior to 2017, people used chemotherapy to treat Merkel cell carcinoma that had spread throughout the body. That had a 5% chance of long-term benefit. 60% or more of patients would have their tumor shrink initially really nicely, but that control lasted 90 days on average from the first chemo treatment. So, sometimes the chemo treatments went quite a while, and so they were recurring during chemo or very close after. And we know now that chemotherapy is very immune suppressive. So while it kills the cancer cells, it also suppresses the body's ability to control the cancer in a more meaningful way, really, which is using the immune system. So that's where we were 2017 and before. 5% long-term control, 60% control for a few months. Where we moved to after immunotherapy was 50%. Long or medium long, at least, control with immunotherapy. So approximately a tenfold improvement in patients who would have more than a year of control. A chunk of the others never have a response from immunotherapy, and another chunk have a response that lasts some period and then eventually stops. So we want to increase that, of course, going forward, but it's a big improvement starting in roughly 2017, and we're very optimistic about getting that number up originally from 5% to 50, and now hopefully towards 75 or even higher.
What is the difference between surgery and radiation for the treatment of Merkel?
So both surgery and radiation are important in early management of Merkel cell carcinoma. And sometimes you're done after that. You don't need anything infused or anything. A lot of times you're done after that. Surgery is great at getting out the bulky cancer, unless it's really, really big. And radiation's magic is to take a much bigger area, like 5 centimeters, all around the tumor, and basically sterilize it of cancer. And the magical, important concept about Merkel cell carcinoma that's different from any of the other more common skin cancers is that it does not grow like a ball. It doesn't grow like a ball with roots either. It grows like a ball that sends out seeds 1, 2, 3, 4 centimeters beyond where the tumor is. It's not sufficient. Very commonly, this cancer will recur 1 or 2 centimeters beyond a pathologically, microscopically negative edge of what the surgeon cut out. So that's why radiation is so effective. And the exciting development in radiation now is you don't need much of it. just one dose of 8 gray to that area will essentially sterilize any microscopic disease there. I'm not talking about for big chunks of cancer. You need more for that. But for the microscopic disease that's very commonly present and is the rationale for why the textbooks say you got to cut 2 centimeters of normal tissue. You got a tumor. You got to go 2 centimeters beyond that to have confidence. Radiation can manage that instead. And if you've got the major chunk of tumor out by surgery, you can really be done and go to radiation. The Australians take it even one step further. They often say, we're done with surgery after the original biopsy. We just radiate that primary tumor and radiate around it, and we radiate the nearby lymph nodes, and we don't do a sentinel lymph node biopsy. And, you know, that's not going to fly exactly in the United States, but it works there. It's pretty good. And certainly the concept of you don't have to have a huge margin and you can treat with radiation very effectively. I think anybody who's really looked at these data will agree with that.
If one immunotherapy doesn't work, will another one work?
Yeah, I'd say it's actively changing. So let's assume we're talking about the first immunotherapy being one of these PD-1 pathway blocking agents. There's 3 that are approved for Merkel, and they all block the same pathway. It's very uncommon. Let's call the 3 Coke, Pepsi, and Dr. Pepper. They're very similar. They taste and look very similar, kind of thing. It's unusual if you switch from Coke to Pepsi that you're going to suddenly see a benefit. So that's really, people don't do that. They don't just switch within one of those same pathway agents. They would normally add a pathway and try and stimulate that way. And I think that is that's the right thing to do. And you're more likely to have benefit. The other thing that we can do, especially if it's only 1 or 2 lesions that may be not responding, we can add a little radiation to the stubborn ones and then use the immune to kill the big burden of cancer, and then use the immune system to do what it's really magical at, which is to get rid of microscopic small amounts of disease. We know that when we get rid of the big cancer and we leave a small amount, that the immune system has a much better ability to then focus on the small microscopic bits and get rid of those.
Now in 2023, when should chemotherapy be used to treat Merkel cell?
We don't use chemotherapy for Merkel cell extremely often. It would not be an early go-to thing for most patients with advanced disease. A few of the settings where we use it are when a person has very advanced disease, kind of heavy burden, and we're afraid that immunotherapy might not work and we've got to get something that's going to work soon, because chemo is probably a little more likely than immunotherapy initially to work and shrink the cancer, especially for a rapidly growing one. So again, if a person has a big burden of cancer around critical organs or something, that's a place where we might consider using chemotherapy. And we probably wouldn't go 6 big treatments of chemotherapy. We'd do 1 or 2 or 3 usually, and hopefully we get a nice response, and then we switch to immunotherapy before the immune system has gotten too battered by the chemotherapy. That's one setting. Another setting is when a person has a bunch of autoimmune disease and they can't get these immunotherapies, which do turn on the immune system and make autoimmune diseases more likely to happen. An especially appealing time is when a person has a Merkel, would benefit from chemo, and they actually have an autoimmune disease that means they can't get immunotherapy, and that autoimmune disease would also benefit from chemotherapy. That's a kind of a twofer. We can suppress the immune system to, help the autoimmune disease and then also help get rid of the cancer. But it's hard to win the whole war in those people. We're talking about a strategic battle or two. But without using the immune system more intelligently, it's really hard to beat it.
What are the side effects of Merkel cell treatment, and how can we manage those side effects?
Each treatment has side effects that are perhaps a little bit obvious. Surgery, you get scars. You get damage to nerves, that, maybe you can't move your face the same way that you used to. You may lose function. You take off a finger, you do a giant excision on a buttock, and then you can't walk properly because you've lost key muscles. Radiation, depending on where you radiate, all kinds of side effects. The toughest is in the head and neck, where you lose taste and you lose your ability to swallow, and you may develop nosebleeds in a persistent way, and your mucous membranes maybe get extremely dry. You lose saliva, and that damages your teeth. The hardest is the eyelid. That's really tough because you lose all the lubrication, and instead of having a lovely soft eyelid that opens and closes, you've got a piece of sandpaper rubbing across your eye, and that's really miserable. So in a way, those are kind of obvious. And immunotherapy, you can have your immune system attack your hormone-making glands. The thyroid is the most common, but many parts of the body, essentially any part of the body, could be attacked. So expected side effects, conceptually, from cutting and radiating and stimulating the immune system, I think the best power that we have to minimize those, once we've given the treatment, we can't undo that, but is to not overtreat. That's the biggest thing that we have. And I have seen all kinds of horrible side effects years later. Some of the most scary ones are the radiation late side effects, where really a lot of radiation can lead to other cancers that are, frankly, much more aggressive than Merkel even. That's not from the normal amount, that's from repeated big courses. And then bone destruction in the face. That's a real big problem. The bones just start to not have strength anymore. And that you're talking about the bones that hold the teeth a lot of times, and so you lose teeth and you lose structure of your face and get infections. That's really miserable. So the goal is, how do we not overtreat?
How has treatment changed in the last 10 years? And how will it change in the next 10?
For patients with early disease, we have a much better sense of how to use surgery and radiation together with personalized risk assessment that I think then combines with blood tests to mean that initial treatment is much less toxic, surveillance is also less toxic financially and logistically, and more effective. We're finding cancer earlier, we're tracking lower burdens of it, and we're having fewer false alarms. So there's a lot of progress in those zones, and we have a much better sense of how we need to use a certain amount of surgery and a certain amount of radiation. And when we use it wisely, we don't have nearly the negative impacts of giant surgery or the negative impacts of massive radiation, and yet we get all the bang for the buck, or even more, by doing it smart and in a combined way. And no radiation oncologist can manage that. No surgeon alone can manage that. That's a team effort with data in order to give patients the best outcome. So there are multiple trials of other agents. Some of the immune therapies involve injecting directly into the tumor and turning on an immune response in that tumor and reversing an immune suppressive environment that the tumor builds. Think about it. You're a tumor, you don't want to be seen. One of the things you do is shut down the local immune system. And there's a whole bunch of ways that a tumor can do that. And we now have drugs that can be injected directly in that counteract that and make the environment in the tumor very favorable for a good immune response, and kill some cancer cells, and then help the PD-1 pathway blocking drug work better through all those mechanisms.